Marcus is 34 years old, and this morning his biggest problem is that he's late for work. Yesterday, while digging through a filing cabinet, he nicked his hand on a sharp metal edge. It wasn't dramatic, no blood everywhere, no trip to the emergency room. Just a small cut, a bandage from the office first aid kit, and back to work. By lunch, he'd forgotten it happened. By Thursday, he can't stop thinking about it. The skin around the cut is red, swollen, warm to the touch. His wife, Sarah, tells him to get it checked out. Marcus says he will, then he doesn't, because he has meetings, deadlines, a presentation that afternoon. And besides, it's probably nothing. Friday morning, the redness has crept past his wrist. Sarah takes one look at it and grabs the car keys. The doctor at urgent care seems unconcerned, which oddly enough is reassuring. She examines the wound, asks a few questions, and writes a prescription for amoxicillin, a routine infection, a routine antibiotic, a routine day. Marcus picks up the prescription on the drive home and swallows the first pill with a bottle of water. That should have been the end of the story. It wasn't. What Marcus doesn't know is that the bacteria inside his hand have seen this drug before. Not inside him, inside millions of other people. For decades, antibiotics have been prescribed, misused, overused, and sometimes stopped halfway through treatment. In hospitals, in communities, on farms. Every time an antibiotic kills the weakest bacteria, the strongest have a better chance of surviving. And bacteria are remarkably good at learning. Some can even share resistance genes directly with one another, passing along survival advantages in a process known as horizontal gene transfer. It's less like a battle, and more like a group project, where the bacteria keep sharing the answer sheet. By Sunday, the clinic calls. The lab results are back. The infection is resistant to amoxicillin. No problem. There are other antibiotics. A second prescription is called in. Stronger, broader. Marcus starts taking it immediately. Monday night, Sarah notices the redness again. It's spreading. Tuesday morning, Marcus is in the emergency room. The infection has entered his bloodstream, and suddenly the situation changes. Doctors have a word for this stage. Sepsis. It's one of the body's most dangerous responses to infection. When bacteria gain enough ground, the immune system can enter overdrive, triggering widespread inflammation that begins damaging the body's own tissues and organs. It's like a fire alarm so powerful that it starts destroying the building it's trying to save. Marcus is admitted. IV antibiotics, blood tests, monitoring around the clock. Her name is Dr. Osei. She's spent nearly 2 decades treating infectious diseases. When she reviews Marcus's chart, she becomes very quiet. Not because she's panicking, because she's thinking. The second antibiotic isn't working as well as it should. The options are getting narrower. Marcus notices the tension immediately. Patients always do. "Am I going to be okay?" he asks. Dr. Osei pauses, then gives the most honest answer medicine sometimes has. "We're going to do everything we can." That night, Sarah sits alone in her kitchen after putting their 7-year-old daughter Lily to bed. The house is silent. She opens her laptop and starts searching. Antibiotic resistance, drug-resistant infections, sepsis survival rates. She probably shouldn't, but she does anyway. What she finds is unsettling. Every year, more than 1 million deaths worldwide are directly attributed to antibiotic-resistant bacterial infections. Not associated with them, not linked to them, directly caused by them. Organizations around the world have warned that antimicrobial resistance is one of the most serious public health challenges of our time. And for the first time, those warnings don't feel like statistics anymore. They feel personal. But the story actually starts long before Marcus, long before Sarah, long before modern hospitals even existed. For most of human history, infections were among the leading causes of death. A deep cut, a tooth infection, a scratch that became infected. Any of them could become life-threatening. Today that sounds absurd, because antibiotics changed everything. When penicillin became widely available in the 1940s, it transformed medicine. Suddenly, doctors could treat infections that had terrified humanity for centuries. Surgeries became safer. Childbirth became safer. Cancer treatment became possible on a scale that had never existed before. Modern medicine wasn't built entirely on antibiotics, but it absolutely depends on them. Take chemotherapy. Cancer treatments often weaken the immune system. Patients survive not only because we fight the cancer, but because antibiotics help protect them from infections while their bodies are vulnerable. Or consider organ transplants. Doctors intentionally suppress the immune system to prevent rejection. Without reliable antibiotics, many of those procedures become far more dangerous. The same is true for premature babies. Major surgeries, intensive care units. Much of modern medicine quietly assumes that bacterial infections can be controlled. Marcus's story matters because it reminds us that this assumption is not guaranteed. Back at the hospital, Dr. Ose is making calls. More tests, more consultations, more options. One conversation leads her to a research center working with treatments that may help in highly resistant cases. Among them is something most people have never heard of: bacteriophages, viruses that infect bacteria, not humans. Bacteria, scientists discovered them more than a century ago. Interest faded when antibiotics worked so well. Now, as resistance grows, researchers are taking another look. The science is still developing. The challenges are significant. But in some documented cases, phage therapy has helped patients when conventional antibiotics failed. It's not a miracle. It's not science fiction. It's one of several approaches researchers are exploring in a race that most people don't even realize is happening. Fortunately for Marcus, the doctors still have options. Not easy options, not risk-free options, but options. Slowly, the infection begins to retreat. The fever breaks, the blood markers improve, the swelling starts going down. 11 days after entering the hospital, Marcus finally goes home. Exhausted, grateful, alive. A lot of things had to go right for that ending. The right specialists, the right hospital, the right treatments, the right timing. Change any one of those variables and the story could have ended very differently. And that's what makes antibiotic resistance so unsettling. It doesn't arrive like a disaster movie. There's no explosion, no dramatic warning siren. It arrives looking ordinary, a scraped hand. A routine prescription, a Tuesday morning. The frightening part isn't that medicine doesn't know what to do. It's that sometimes medicine knows exactly what to do, and the bacteria are getting better at ignoring it. For nearly a century, antibiotics have quietly protected us from dangers most of us never think about. They helped turn infections that once killed millions into problems solved with a prescription and a glass of water. That window is still open, but it isn't guaranteed to stay that way. And if we want future generations to inherit the same protection we've taken for granted, the time to pay attention isn't when the options run out. It's now.